over the years, he's become a doctor to quite a lot of us, and certainly a friend to all of us. The presentation tonight was a special request of our advanced recurrent group that meets prior to this meeting. Bob Moore came to director's meeting several months ago and had a lot of questions that were coming up in his group, and he said that he would really appreciate it if we could get Dr. Lamb to come down and answer a good half a dozen key comments and questions that kept recurring in his recurrent group, and Dr. Lamb was kind enough to oblige, so we really appreciate that. And we thank Bob Moore and the rest of the guys on that group for their service. So Dr. Richard Lamb, here before us tonight, received his undergraduate degree in biology, magna cum laude, at UCLA. Not a bad school. Happened to went there myself. And he went on to earn his medical degree also at UCLA, at the UCLA School of Medicine. And he completed his residency and training in the specialty of internal medicine at the UCLA Center of Health Sciences. He then completed his oncology and hematology fellowship at Harbor UCLA Medical Center. And he's been specializing full-time, which is very important, in the treatment of prostate cancer since 2001. He's partnered with another very good friend of ours, Dr. Mark Scholes, and he's the director of the research arm at the Prostate Oncology Specialists in Marina del Rey. Dr. Lamb has written several articles based on his research. He's an active member of the American Society of Clinical Oncology and the American Society of Hematology. He also provides free prostate cancer management advice to patients at patient to physician, that's P2P, which can be found at the www.pcri.org website. Very great resource. For those of you that don't plug into it, it's a wonderful resource. I encourage you all to do so. Dr. Lamb continues to promote prostate and education by giving lectures at various medical conferences. We see him every year at the local one in LA, and also at various prostate cancer support groups like ours. He's presently researching, among other topics I'm sure, the side effects of testosterone inactivating pharmaceuticals, and especially their side effects on bone integrity. I'm sure he'll comment on that this evening as well. So without further ado, let us give a great welcome to our guest, Dr. Richard Lamb.
Thanks, Larry. Good evening. So I presume the Democrats are on the left and the Republicans are on the right. So I'll give the speech and I'll talk like Obama tonight. So very slow and clear, and I'm kidding. Okay, so the top. Thank you very much for having me here. It's always fun to come talk with you guys. It's very smart, and you guys ask really good questions, and you know, I've always enjoyed coming here. So thank you very much. The topic tonight. You know what? Since I have this thing here, I'm going to do something I've never done before. I'm going to walk a little bit, so I'm not stuck behind this pulpit. So the topic tonight, as you guys are aware of, is hormone refractory or advanced prostate cancer, which they're somewhat synonymous, and you know, we'll go over various different treatments and strategies on how to manage this you know, very difficult, challenging situation. Next slide, please. So when one treats hormone refractory disease, we're typically treating the whole body rather than directing treatment specifically to the prostate or you know, the pelvic region. So you got to think of treatments that basically go into the bloodstream. So the various treatments are as follows. There's the traditional hormone therapy or secondary hormone therapies. Then there's usually the next step after that is some sort of chemotherapy, be it via pill form or intravenous form. There are some somewhat experimental, not approved yet, approaches to treating systemic hormone refractory disease using the immune system. And then on that note, there's some other experimental agents in the pipeline as well. Next slide, please. So the first type, a little background, prostate cancer traditionally is very hormone sensitive, meaning by manipulating the hormones, one can treat prostate cancer very successfully. The goal is simply to starve the cancer from testosterone. And so you either take away the testosterone or you try to prevent the testosterone from reaching the cancer cells. And usually, this approach, androgen blockade, testosterone deprivation, it works for many years. So, next slide, please. And based on some studies, from the VA, we think on average it works for about 10 to 11 years. I tell patients we're going to do hormone blockade. If you're, the average is 10 to 12 years. There are cases where it only works 1 to 2 years. There are cases where it works 15, 20 years. Okay? But the average is about 10 years. So next slide, please. So a typical scenario is this timeline here, and this is actually, this vertical graph is PSA. This is over time, if you're using hormone blockade intermittently, you can control the cancer or the PSA. When it goes up, you start hormone blockade, and the PSA will drop, but when you stop hormone blockade, the PSA will go up again. You resume hormone blockade again. So at some point, 5 to 15 years from the initiation of treatment, the cancer or the PSA will grow despite hormone blockade. So that is called testosterone or hormone-resistant disease. And there's many mechanisms to why cancer cells develop this resistance, where taking away testosterone fails to control the cancer. So the approach is how does the cancer get around this treatment? So if we know exactly how the cancer gets around it, then we may be able to find ways to target our next line of therapy. Next slide, please. So the various systemic treatment options for hormone refractory disease are all these things here. So I'll go over all of them, basically. Estrogen, secondary anti-androgens, ketoconazole. These are some chemotherapy agents. These are some experimental agents that hopefully will be on the market in the next year or so. Next slide, please. So the first approach to, if a patient's on Lupron or Casodex and the PSA starts rising, if their disease is not that extensive and they're fairly comfortable and not symptomatic, we have the luxury of time to try some other anti-androgen approaches. It turns out that cancer cells, when they become resistant to testosterone blockade, it's actually it's not a true description. They're actually still sensitive to testosterone deprivation, but they've found ways to either get more testosterone or utilize whatever little testosterone the body has to grow, or sometimes cancer cells can make their own testosterone. So they're actually still hormone sensitive, but they're just super hormone sensitive. So the first line of blockade stops working. So these approaches are essentially ways to find other ways to deprive the cancer of testosterone. So next slide, please. So one of our favorite approaches, which surprisingly is not used by many other doctors, is simply by stopping Casodex, and sometimes you get what we call a Casodex or anti-androgen withdrawal syndrome. So you take away the Casodex, and actually the PSA will drop on its own. So the reason why is maybe the Casodex actually starts feeding the cancer. Another approach is to substitute Casodex for nilutamide. So let me digress a little bit. The way Casodex works, or the way Lupron works, is you get a shot and your body stops making testosterone. Okay? So the way Casodex works on top of Lupron is whatever testosterone is still in your body, it could still reach the cancer cells. And by giving a patient Casodex, you're actually blocking the mouth of the cancer cells so that the little bit of testosterone in the body does not reach the cancer cells. So Casodex, as I tell many of our patients here, is like a piece of tape on the mouth of the cancer. So when this combination stops working, simply replacing the tape with a different piece of tape, such as nilutamide, oftentimes results in a PSA response. One of the first studies were actually 2001, 2002, but this is a slightly larger study that was published, which showed that of the 28 men who were on Lupron and Casodex, or Lupron and flutamide, about 18 of the 28 patients who subsequently tried nilutamide had a PSA decline. And 8 of the 18 patients, their PSA actually declined more than 50%. So some men with nilutamide, it only worked for a few months as a backup plan. Sometimes this little manipulation could work for a couple years. And one of the signs that this nilutamide would work is if, for example, your doctor took away the Casodex and indeed your PSA dropped, but then it started going up again. Then by giving nilutamide, the PSA will drop again. Next slide, please. This is another study with slightly more men, 45 men. Same thing, androgen-independent prostate cancer. They've had Lupron and Casodex or flutamide. Ulixin stopped working. And they treated all these men with nilutamide. About 40% of these guys, their PSA subsequently dropped by about 50% or more. In fact, there were a few guys in this trial that simply changing pills suddenly made them hormone sensitive again for up to 4 years. So imagine if you were told, oh, you're hormone refractory and you better go on chemo, and instead, you try nilutamide and suddenly you're not hormone refractory again. You could go back to intermittent blockade, and so you don't have to do chemo for a long time. So it's a very easy approach. Next slide, please. However, nilutamide is still not a perfect drug, just like any drug nowadays. There are some potential side effects that you have to be aware of. One of them is just the adaptation to light and darkness for visually. So if you go from a bright outdoors during the daytime and you suddenly go inside, when you go in, everything, the darkness of the inside, it makes it hard for you to adapt to the change in light. It interacts with alcohol, so some men who like a little wine or something, wine and nilutamide could cause some severe dizziness. And some men get nausea, and about 1 out of 20, 25 men, their liver enzymes will be abnormal, so you need to, the doctor needs to check for that. And one very important side effect that is very preventable is lung damage. And so about 1 out of 100 guys, they get this allergic type reaction to this medicine, this pill, and it tends to occur fairly early in the treatment course. And if you recognize it and you stop the drug, the lungs generally improve and resolve. But if you stay on the drug because the PSA is dropping, there's a chance you could get permanent lung damage. So, next slide, please. Estrogen is another hormonal agent that also has basically other mechanisms of testosterone blockade. And we think that basically estrogen further suppresses testosterone on top of the Lupron. So it may suppress it more inside the cancer cells and in the bloodstream, and it may suppress other androgens other than testosterone. And so, and we know that in many studies nowadays, the response rate is between 25 to 80%. However, it's not as popular as before because there's quite a bit of, next slide please. So some of these, among them, the side effects are blood clots called thromboembolism, and these clots can go anywhere. You know, if it goes into the brain, it's a stroke. If it goes into your lungs, it's a pulmonary emboli. And so you know, we can use estrogen, but we just have to be aware of this complication. And sometimes, most of the time, by preventing, by giving a patient, especially someone at high risk, some blood thinners such as warfarin, you can decrease the risk dramatically. So on that note, estrogen patches have been thought to cause less blood clots. So there are some studies using estrogen patches to see if there's a similar benefit. My feeling is estrogen patches indeed do not cause blood clots. Well, very often, very rarely, I think. I haven't seen one yet. But I don't think it works as well. So instead of a 50-60% chance of working, the patches probably have about a 30% chance of working. And estrogen also may cause some fluid retention and congestive heart failure. And intuitively, estrogen may also cause some breast swelling. Next slide, please. But there are some benefits to estrogen. It's one of the few hormone therapies that actually help maintain bone density, and you know, just that's why women take it. And when people take estrogen, their hot flashes from Lupron tend to be much lessened. And you know, maybe a lot of patients feel that they feel a little sharper once they start estrogen too. So there may be some improvement in mentation and cognition. Next slide, please. The next couple medicines I'm going to talk about are based on this inhibition of this enzyme called CYP17. And this enzyme is a very prominent enzyme in testosterone, androstenedione, DHEA, progesterone. All these various testosterone and testosterone cousins rely on this enzyme to be produced. So intuitively, if one can block this enzyme, you could do a better job of blocking testosterone. So one of the older drugs is ketoconazole, which has this mechanism. And now there is a newer drug that's being actively studied in our office called abiraterone. Next slide, please. So this is a little summary of our experience with ketoconazole before abiraterone became available. And we looked at our charts and our cases of the about 78 men over a period of 8 years, and we wanted to see how they did on ketoconazole. So most of these men had bone mets, and the average median PSA was 28, and these are hormone refractory guys. And if you, of the guys who took ketoconazole, and it worked, on average it worked for about 7 months. And about the top 25% performers, meaning the top 19 guys who responded, they actually had an average of about 1.5 years of benefit from ketoconazole. Next slide, please. We found that on average, the guys who do not have bone metastases, they did very well on ketoconazole. About 8 out of 10, 9 out of 10 guys responded. The men who had bone mets, only about, still I was okay, I was happy. Half of the men did have a response. And there were a fairly significant group of men, 40% of the guys, their PSA dropped more than 80%. And again, if you don't have bone mets, you have a higher likelihood of dropping your PSA 80%. Next slide, please. Next slide, please. So in the guys who had a PSA drop of 80%, they were able to stay on the medicine and control their cancer for 2 years and 4 months. So I think from our experience, it looks like the guys who really benefited from ketoconazole are the guys who responded who had a nice response of 80% PSA drop or more. So next slide, please. However, ketoconazole has a lot of potential side effects. It's kind of a hassle to take. It could cause nausea, ulcers, heartburn. Your liver needs to be monitored. There's a ton of interactions with other pills. It could cause what we call a sticky skin syndrome, and it's and you got to take it 3 times a day on an empty stomach. So a lot of our guys, you have to kind of plan your day around taking these pills. So it hasn't really been a popular, well-accepted drug even in the medical community just because of all the complications. Next slide, please. So along comes abiraterone, which is a cousin of ketoconazole, but it appears to have significantly less side effects. And it's a lot easier in terms of ease of use. It's just 4 pills at 1 time a day. And in the earlier studies at UCSF by Dr. Ryan, he found that almost all of his patients who took it had a PSA drop. Okay, so it worked for a lot of men. About half of the guys, their PSA dropped more than 50%. So only 1 guy out of 25, his PSA actually kept rising. Okay, next slide, please. So let's see here. It also looks like, so subsequently there have been more phase 2 studies where everyone gets the drug and the doctors wanted to see how these guys are responding. And the most recent abstracts that came out, let's see here. So this was an update of Dr. Ryan's studies, and he found that there was an 85% chance that the PSA will drop by 50% before you needed to take chemotherapy. Even in men who've had chemotherapy and their PSA started rising again, by going on this drug abiraterone, about half of the guys again had a response in their PSA. So subsequently, after these promising phase 1 and 2 studies, the company was bought out by Johnson & Johnson, and then the phase 3 trials have accrued, are accruing very quickly. The first phase 3 trial was for 1,000 men, and it was for patients who've had chemotherapy and the PSA is rising again. So that study has actually closed to accrual, and we're just waiting for some data. And I think we'll hear some data in about maybe 4 or 5 months. And that study is a phase 3, meaning it's the last phase before the FDA can look at the data to see if they'll approve it. So it's what we call a placebo-controlled study. 2/3 of the men who participated in the trial got the drug, 1/3 did not. So we were part of that trial. We enrolled, I'd say, about 30 guys actually. And now we're doing the second phase is the same trial. It's the O2 trial, and it's for men who have hormone refractory androgen-independent disease with metastatic lesions, and but they don't really need to have chemo yet. So it's kind of a treatment before chemo. And this trial is accruing fairly fast as well. And this is a 50-50. So these guys are less sick, so the company felt that, well, they don't feel as they could split up the patients in a 50-50. So there is a 50% chance you get the drug and a 50% chance you do not get the drug. And that, I think that should finish accruing in the next few months as well. Next slide. So another compound called MDV-3100, it's named after the company Medivation, and it's their one and only compound. And this is a drug that works similar to Casodex and nilutamide, but probably stronger and at a few other levels. And so again, it's to block testosterone from reaching the cancer cells. And it looks more effective than Casodex in these situations, and looks a little bit more effective than nilutamide too. About 60% of the men who have androgen-independent disease, by switching to Medivation, they had a PSA response. Most interesting, though, was the data that came out last year was Dr. Sher at Sloan Kettering found that even in men who had chemotherapy and their PSA started rising, by simply going on this pill, there was about a 50-60% chance they'll control the cancer again. So very promising. This is a phase 3 trial, which our office is also participating in. So this trial is after chemotherapy and your PSA is rising, you would be randomized to either the pill or placebo, 2/3, 1/3 separation. And again, this is accruing fairly quickly as well. Next slide, please. So I just want to give you a typical patient who presents with hormone refractory disease. These are actually men that we've seen over the years. This is a gentleman who came about a year and a half ago with hormone refractory disease, and his PSA was about 30, and we said, let's just try, and he had two little spots of metastatic disease that were not causing him any symptoms, so we thought, well, let's just try something hormonally. So we switched him to nilutamide, and his PSA did indeed respond, and it dropped to about 6 or 7. And we controlled it. It was going up slowly, and then the cancer somehow became smarter and became resistant, so the cancer started growing despite nilutamide. So it went all the way up to about 39, 40. And it went up fairly quickly, and he said, well, I really don't want to do chemo. I'm a full-time, I work full-time, and I can't come in for chemo. I don't want to lose hair. I don't want people to know that I'm, sick. So let me try something else. So we tried ketoconazole with a little bit of leucine, and fortunately, actually with him, we gave him ketoconazole and leucine, and luckily his PSA is again coming down. So this is over about a 18-month period where for many patients, oftentimes when their PSA is this high, they may be told, well, you better just do chemo. Next slide, please. So, speaking of chemo, there is a role for chemotherapy in this disease, in this situation, and these are some approved. These are some drugs that are available for hormone refractory prostate cancer. This is a very old drug that we actually use for lupus and some other autoimmune diseases called cyclophosphamide, and at very high doses, we use it for breast cancer and bladder cancers and a bunch of other cancers, not bladder, but other cancers. And at a very, very low dose, it turns out that even with this pill that you take, there is still about a 1 out of 3 chance that you can get a response. So this drug has been around for a few decades. Mitoxantrone was approved in 1999 because it worked in the sense that it did drop the PSA in some patients, but it really didn't prolong life in the whole population. So they approved it because it did help with patients' pain, and they felt better even though they were on an IV chemotherapy. And then slightly more recently, 6 years ago, Taxotere was approved because it actually they compared it to mitoxantrone, and there was some improvement in survival as well. Next slide, please. So this was one of the studies that got Taxotere approved. Taxotere plus MCIT, which is another older chemotherapy pill, was compared to mitoxantrone and prednisone. And this was a large phase 3 study, which you have to do before FDA will approve anything, of almost 700 men. The average PSA was 87, and almost all the patients had cancer in, metastatic somewhere. Most of them had cancer in the bones. And they found that Taxotere improved the likelihood of shrinking your PSA, the likelihood of living longer, and when you responded, you can respond longer than if you responded to mitoxantrone. Next slide, please. And then this was another study using Taxotere compared to mitoxantrone. And again, there was a modest improvement in survival. But even compared to mitoxantrone, patients had better pain relief and their quality of life was better. So, one would think, gosh, chemotherapy is not as usually associated with good quality of life, okay? But when a patient has a rising PSA, they have pain, they have leg swelling, they have loss of appetite, weakness, and they're on codeine and morphine all the time because of uncontrolled disease. If you give them Taxotere, which by itself doesn't have too many side effects, and you shrink the cancer, they feel better, and they get off all those narcotics. And that's probably the reason why, even though Taxotere has some side effects, overall patients felt better when they're on chemotherapy. And fortunately, Taxotere does not cause significant nausea or vomiting. Next slide, please. So this is a patient who came to us last summer, and he developed hormone refractory disease, and came here, and he had widespread cancer. His legs were swollen. He had bone pain. He could barely walk. So he's someone that you don't want to say, oh, let's try nilutamide for a few months, or let's try ketoconazole. This is someone that has a fairly short window that you have to do something, and you want to use a drug that is approved and can work fairly quickly. So his PSA was actually 1,800, and we actually gave him Taxotere just once a week. He was like 70 something, and we didn't want to make him too sick or tired, and we got very lucky, and his PSA kept dropping. In December it was about 100, and this January 6th his PSA was 80, and we're actually going to take a break from chemo, and now we're going to try like nilutamide or ketoconazole or even the 2 trials that I've been talking about. So he's a pretty happy camper. Next slide, please. So, however, Taxotere, it really doesn't work forever, and so what happens when Taxotere stops working? So one of the very promising agents is bevacizumab, also called Avastin, and it's called a anti-angiogenesis drug. So it basically cuts down the blood supply to the cancer. And it has other mechanisms as well, but this is the main mechanism. It blocks this enzyme called VEGF. It has been officially approved for these cancers: colon, lung, brain, kidney, and breast. It doesn't work in a couple cancers, but in general, it seems to enhance the response and effectiveness of the chemotherapies we give. And I think ovarian is going to be the next approved indication, and hopefully someday prostate. Next slide, please. And one of the first studies of Avastin and Taxotere that was interesting was a lot of men who had Taxotere and became refractory, meaning Taxotere stopped working. They simply added Avastin to these 20 men and continued the Taxotere. And 11 of the 22 men, their PSA started dropping again. So very promising approach. So sometimes after Taxotere stops working, we just add Avastin, and we see about a 40 to 50% likelihood of some response. Next slide, please. This is another study done by Dr. Dahoud Ning and actually Fig, and they're from the National Cancer Institute and the FDA. So it's a semi-government supported study that used Taxotere with thalidomide and Avastin as an upfront treatment for these very sick men. So they didn't wait for the Taxotere to stop working. They just used all 3 together up front. And all of these men had metastatic disease. Their average PSA was 100. Their PSA was galloping up, doubling every month and a half. So fairly rapidly growing cancers. And so next slide, please. They treated these patients, and really amazingly, they found that of the 58 guys who were treated, 52 of them, their PSA dropped more than 50%. And 44 of the 58 guys, their PSA actually dropped 75%. So it went from 100 to 25, for example. And there's a very good chance if you went on this cocktail, the PSA will drop that much. Next slide, please. This is another way of looking at it. Of the men who were on this cocktail, I borrowed this slide from Dr. Ning, only one guy, his PSA actually went up. Everyone else's PSA dropped on this cocktail. However, we give the most significance to men who had a 50% or more drop. And look at all these men who had that 50% or more drop. And a lot of men, you can see the PSA drop by 80, 90, 95%. So a very effective regimen. Okay. Next slide, please. Next slide. Thanks. Oh, what happened to the other one? Anyway, there is. I guess it disappeared. But to be fair and balanced, I would like to tell you the other side. This cocktail is difficult. It works, but you have to take blood thinners, or else there's a fairly high chance of developing a blood clot. And this was really tough on the nerve endings. So there's a higher risk of getting tingling and numbness in the fingers and toes. So those are very big long-term complications. So another combination that looks promising is using Taxotere and this oral form of 5-FU. It's called capecitabine, and this is a drug that's approved for these cancers, and in these cancers, Xeloda and Taxotere seems to work better than Taxotere. So prostate cancer being left behind, one of the last cancers, slowest researched cancers, finally started studying Taxotere and Xeloda. And next slide, please. And they saw some pretty impressive responses. So if you combine Taxotere with Xeloda, this group found, this Italian group found that about 2 out of 3 men will have a nice PSA drop. In this study by Dr. Marur, 3 out of 4 guys had the PSA drop with Taxotere and Xeloda. And the side effects to be aware of is there is some nausea with this combination as opposed to Taxotere. And some men could get diarrhea, and some men, their hands and their feet could get really red and painful. So slightly better response rates, but you have to pay a little bit of a price from a side effect standpoint. Next slide, please. And these are this is a newer compound that's still being researched, and I'll just call it DMXAA, and it's a small compound. It works similarly to Avastin, and so far they've studied it with Taxotere by itself, comparing it to Taxotere plus DMX, and this was studied at Hopkins. Next slide, please. And at Hopkins, they found that the group that took this combination, there was a higher likelihood of dropping your PSA, and there was a higher degree of drop in their PSA. So the average PSA drop was almost 80%. So it's a very strong responder, as opposed to, on average, if you took Taxotere, the average drop is 36%. Next slide, please. Another compound that is getting a little bit more momentum that was reviewed this year by Dr. Kim Chi is OGX-011. And this is in the Petri dish at least, they found that this compound clusterin that basically promotes cancer growth. So OGX actually blocks clusterin. Okay? So it's an anti-clusterin compound. So they added OGX, next slide please, to Taxotere, and again they found that it seems to be better than Taxotere by itself. So in terms of having a PSA drop and having a survival improvement if you took both of these. Next slide, please. So this is a longer graph of a patient that we met about 5 years ago, and this was a 70-something gentleman who came in and said, oh, he has hormone refractory disease. His PSA was 200, and he was hormone. He was actually hormone sensitive. He just presented with this picture. So we gave him Lupron, And it worked for a little bit, for about a year and a half, a year and 3 months only. So the take-home message is when your PSA is 200, Lupron is not going to work 10 years, okay, or less likely to work 10 years. And so he developed resistance, and we started trying these other agents such as nilutamide and ketoconazole, and it really proved to be a challenging case. And his cancer just, when it decided to grow, it was growing quickly. Okay? So it reached, I'd say, about 700, 600 in about 2 years ago. And we gave him Taxotere, and Taxotere appeared to work for a while. And we stopped treatment here, and his PSA started going up quickly again. So we gave him Taxotere again. It didn't seem to work, so we switched to this combination of carboplatin and Taxol. And again, it worked. And it worked, and it kind of kept things going for a period of time. And then I think we stopped treatment again, and his cancer went up to 900. And he started having severe bone pain. He could barely walk. And we thought, well, let's try something else. Let's try Xeloda, which I went over, and this new drug that is approved for breast cancer called Exempra. And lo and behold, from I think it was October, November, his PSA dropped from 900, and it's about 180 right now. And he's walking, talking, no longer needing transfusions. Drives down here from Santa Maria, once every 3 weeks, and visits friends and gets low chemo, and goes home. So he's alive and he's happy, and he's very comfortable and spending good quality time with his family. So the take-home message of this slide is basically, there are some other even chemotherapy options even when Taxotere stops working. Now, none of these drugs are officially FDA approved, but they're available. And fortunately, living in California, our patients, Medicare does cover most, if not all, of these medicines. So, next slide, please. Next slide, please. And so this is a picture of a person with cancer in their bones. This is a bone scan. And you can see these dark spots here, the scapula, the spine, the pelvis. And, typically, when it gets to this point, patients will start feeling some symptoms. Next slide, please. So one of the ways to, manage cancer that's hormone refractory is not just hormones and chemo. You want to make sure the patient is comfortable. So one of the options is something called Quadramet. It's also known as samarium. I call it IV radiation. So traditionally, if you have a painful area on your bones, actually, can you go back one slide? So for example, if this gentleman came in and said, oh, my back is really bad, or my right hip is really painful, and he didn't want to do any drugs or anything, we can pinpoint some radiation in those areas and take care of that pain. Next slide, please. This samarium it's also radiation, but it's actually injected into the veins. And the compound goes into the bones. So it treats not just specific areas, but it treats wherever there's cancer in the bones. So it seems to be it's approved for multiple cancers. It seems to be pretty effective. It's not, and it can oftentimes cut down or even eliminate the need for codeine and morphine. And you could keep doing it, at least 2-3 times if you need it. Next slide. And so this is these are some pain surveys, and on men who, when they took a placebo, they noticed that they said, oh, my pain is a little bit less, even if you tell them you gave them a placebo. But there was a significant decrease in pain if you went on the samarium. Okay. Next slide, please. So one novel approach was to use samarium Quadramet in conjunction with Taxotere. So the process is let's do 2 different mechanisms rather than 2 chemos. Why don't we do 1 chemo and 1 IV radiation and see if there's some synergy or additive benefit. And maybe this approach will give you a better response. It may prolong life, or practically speaking, maybe it will shorten your duration of treatment or prolong your Taxotere holiday. So those are the goals of this approach. Next slide, please. Especially if you have a little pain too. So these are some series of studies in the last few years that found that it did appear that if you did 6 weeks of Taxotere, which is not a long time, usually we use Taxotere for 12 to 20 weeks. If you use just 6 weeks of Taxotere, you could get, if you gave a little Quadramet, you could get about 5 months of doing nothing. Okay? This study showed that it looked like if you added Quadramet, it may even enhance the survival of patients. These are early studies, though, so you got to take this with a grain of salt, but it does look promising. And this is for this study showed that even when Taxotere appeared to stop working, doing Taxotere and Quadramet sometimes worked. Next slide, please. So we're going to talk a little bit more about some novel approaches. One of the novel approaches is trying to use the immune system to try and treat the cancer. And these are some of the actively studied compounds right now. And GM-CSF is otherwise known as leucine. Provenge is Sapiricel. It's that IMPACT trial. And there's some pox vaccines. Very recently, Dr. Cantor at Boston, I believe, came out with some provocative survival data on this Prostavax pox vaccine. Next slide, please. So briefly, leucine is a growth factor that's actually approved for to stimulate the immune system for men who are getting chemotherapy for leukemia, for example. And however, they found that if you stimulate the immune system, maybe the immune system will be so revved up, it will start thinking that even the cancer is something that shouldn't be there. So that's the concept of the immune system treatment. So with leucine, they found that Dr. Rini found that if you gave leucine, let's see here, by itself for 14 days, about 1 out of 4 guys will have a PSA drop. These are hormone-sensitive patients. So without using Lupron, just giving leucine, your PSA will drop in about 24% of the time. Another group studied leucine with thalidomide. And this is, again, for people who have hormone-sensitive disease. They found that at least 50% of these guys, their PSA dropped by 50%. Again, these are ways to avoid Lupron. Try something different. Next slide, please. So for hormone refractory disease, this was a larger paper with leucine and ketoconazole. Again, this is more in line with today's topic. If you have hormone refractory disease and you use ketoconazole, which is what we talked about earlier, and leucine, there was a very impressive likelihood of dropping your PSA, about 75%. And that's higher than with our experience with ketoconazole alone. Leucine does have some side effects. GM-CSF side effects are achy bones. Leucine is injectable, so there's some injection reactions. People can have, you got to watch the liver because of the ketoconazole. And a lot of it, and some people get various allergic type reactions like watery eyes, runny nose, that type of reaction. Next slide, please. And leading to this topic, this is called Provenge, which is actually the studies are completed now. And the study that is being submitted into the FDA is the study of 500 or so men who were treated with leucine versus, Provenge versus placebo. And this is not as generalized like leucine. Leucine was just to stimulate the immune system non-discriminately. Provenge's goal is to stimulate the immune system to look for cells that express the PAP antigen. And what cells express the PAP antigen? Prostate cancer. So this is kind of a directed vaccine to try to stimulate the body to fight against the cancer inside the body. And they found some modest improvement by 4 months in the group that had the treatment versus placebo. And there was a 38% chance that you'd be alive at 3 years, 38% higher chance that you'd be alive at 3 years as opposed to the placebo. Sometimes these placebo-controlled trials, the benefit, it's hard to achieve a dramatic 5-year difference in benefit because there's so many other variables that equalize both groups. So if you're able to achieve a 3 to 6 month benefit and is statistically significant, the real benefit's actually somewhat higher in the clinical setting. So right now we're just waiting. All the paperwork is in. I believe May 1st is the day that the FDA is scheduled to make a decision on Provenge. Next slide, please. So this is a gentleman who just want to explain, go over this case, which is kind of interesting. And his cancer was fairly aggressive. It went up to about, PSA went up to about 31 or so. And this was about a year and 4 months ago. And we put this gentleman on Taxotere, and luckily it worked. And we stopped Taxotere a few months later. And we've really only been, and the PSA started rising, and all we've been doing is using a little bit of keto, a little bit of estrogen, and a little bit of Revlimid. And the patient is, quite comfortable, not very many symptoms. He's comfortable with the PSA rising a little bit. We all realize that this is holding the cancer for the last year or so. And hopefully we could delay or prevent these spikes like before where he needed Taxotere again. So he's actually been off treatment for about 13 months. And, when the time comes, we may use Taxotere again. Okay. Or hopefully something else that's better. Next slide, please. So what can we expect in the rest of this year in terms of options for this daunting situation? Well, I think there's just going to be, data takes a long time, but at least there's a lot of promising compounds and a lot of studies going on now. So even when the studies take time, we should get some data, probably some promising information, a couple times a year now, as opposed to a couple times a decade before. So these are some drugs that are very promising. As you know, these drugs we talked about, Provenge we briefly talked about this. This is another immune type treatment which we're going to be part of a phase 2 trial in a month or so for hormone refractory patients. This is called ipilimumab. It's also an immune-based, very promising compound. So I think that is the end of the talk.
And I'm curious as to whether or not when you have a patient who is on Lupron and Casodex and the PSA begins to rise again, and prior to going on chemotherapy, I've heard some good reports of dropping the Casodex and adding thalidomide. Have you had any success with any of your patients of that combination?
We've dropped Casodex, and usually the response is about 1 out of 4 guys. And the duration of the PSA dropping off is a few months, like 2 to 4 months. Using thalidomide in this situation, on average, I would say about 1 out of 4 guys will have a PSA drop. To do the dropping Casodex and starting thalidomide by itself simultaneously, rather than dropping Casodex and then doing thalidomide, I would say we haven't used thalidomide as much in the last 3 years, mainly because there's about that 25-30% response, but it's fairly hard in terms of side effects. Neuropathy, constipation, fatigue.
Would you prefer then to have your patient stay on Casodex and add the Lupron along with the add the thalidomide along with the Lupron and Casodex?
Yeah, we tend to do that more often because the Casodex stopping part doesn't seem to last that long.
Thank you.
shy, is a good
But
chance to
the,
talk to Dr.
Revlimid, which is a newer version of thalidomide, has less side effects. So we're using Revlimid a lot more now.
Good evening, Dr. Lam. Thank you for your informative talk. I wonder, is there any attempt made to use any of the alternative treatments to delay cancer becoming
Hormone refractory?
refractory? Yes.
Uh-huh.
Now, we're starting earlier before it became refractory with any one of those treatments you mentioned. It has been any attempt to see whether it prolonged the period until it
With did you say alternative
Yes.
options? Well, you know, I think the key to delaying hormone resistance is trying to stay away from hormone therapy if possible. Delay the need for a second round of hormone therapy when you're doing intermittent therapy. So during this off period between hormone therapy cycles, this is an ideal time to try alternative supplements, vitamins, and see if there's any PSA effect with these interventions. On that note, you know, in terms of really well-studied trials, we haven't had too many impressive ones except for pomegranate juice. But anecdotally, we see a lot of our guys who are super motivated, who really lose a lot of weight, go on a vegan diet. Their PSA velocity or slope really changes dramatically. So from an alternative standpoint, I think diet and pomegranate, maybe vitamin D and omega-3 fatty acids would be something I would do.
Thank you very much.
This may be a naive question, but it seems PSA is a very strong indicator of what's happening in the body. At what PSA number does one say, okay, it's time for chemo?
Sure. You know, setting aside the exceptions where a PSA of 5 could still represent florid metastatic disease, you know, I would say I'm comfortable waiting. I don't want to wait till a lot of these studies where chemo was used, the PSAs were 70, 80, 90, 100. You know, I'm not as I don't wait that long. I would say about 20 to 30. I would start thinking about chemo.
Dr. Lamb, terrific presentation. Thank you.
Thanks, Murray.
Thank you. Your last answer just prompted my question. There's been a great deal of investigation and even recommendations before reducing the risk of prostate cancer with various supplements, pomegranate, curcumin, etc. Is there any evidence that after diagnosis, after treatment, that some of those things which we hope will reduce the risk before work after we have it, and we're trying to keep it from returning?
So this is preventing relapse, right?
Preventing relapse, making sure that, preventing relapse, that sums it up.
With supplements and alternative treatments, or
Yes.
not
Are there any that seem useful, or is there any evidence that any of them work?
not enough evidence. I think a lot of these, first of all, the supplements and lifestyle changes work better for low-grade cancers. So if you have a grade 8, 9, or 10 disease with multiple metastatic lesions, drinking pomegranate juice is not going to do it. But for men who have Gleason 6 disease, their PSA is gradually going up, and of course we don't want to do Lupron or anything yet. The interventions we talked about earlier have some observable benefit, but does it benefit everyone? No, but it's worth a shot. Is there a treatment that we recommend, or intervention that we recommend, let's say if your PSA is 0 and you wanted to prevent it from going to 0.5, for example? Not enough, no studies yet, except in breast cancer. They did show the ladies who went on a low-fat, low-sugar, lived an active lifestyle, they were observed to have a lower breast cancer relapse risk. So there's probably something there, because those are very good studies.
Heart healthy,
Yeah.
cancer healthy.
Yeah, Dr. Lamb, I have a two-part question. First of all, you talk about pomegranate juice, and I recognize that they've had tests that show that improves, but it's high in calorie. Can you get just as much benefit from pomegranate supplement as you can the juice?
Well, the answer is yes, especially the one that's made by the company that makes the juice. They seem to have made it pretty equivalent. But interestingly, the study that showed the PSA benefit was juice, and the juice had sugar in it. So, maybe if they use the sugar-free juice, you'd have it even better. That would be the next study, I guess.
Good for the cancer, bad for the waistline. Huh?
Right.
Okay, now referring back to the SELECT trial, the vitamin E versus the selenium trial, and admittedly that was a faulted trial, but would you still recommend that you take a vitamin E supplement and or a selenium supplement?
Actually, I don't. It probably isn't harmful, because the first thing we want is do no harm. But surprisingly, some of these vitamins are associated with diabetes, worsening of lung cancer. So we think vitamins are harmless, and based on the study, I think I'm just going to say the jury's out. So until the jury's in again, I'm going to say you don't have to take it.
Okay, would you differentiate between vitamin E, alpha, and gamma?
Well, I mean that's the gamma is the good one, and the alpha is supposedly the bad one. So that's all theoretical. Yeah.
Thank you.
Thank you, Dr. Lamb. My question is your office running some trials now, or are you anticipating some trials that some of our people might be able to get into? Could you talk a little bit about that?
Sure. So as of today, we have 2 active trials that are accruing. The first one is the abiraterone pre-chemotherapy metastatic disease hormone refractory trial. So you have to have hormone refractory disease, have to have at least one spot of metastatic disease. Your PSA has to be rising. You cannot have had chemotherapy. So you're not very sick, but the PSA is going up. So that is a 1-to-1 randomization phase 3 trial. That means that there's a 50% chance you do not get the drug. And you are monitored every 2 weeks, blood tests, you get scans very frequently. So if things do progress, you're not obligated to stay on the trial. The second trial is the MDV 3100 trial, and that is a after chemotherapy metastatic hormone refractory situation, rising PSA. And so you had to have had Taxotere, and your PSA is rising. And that is a 2-to-1 randomization, and that's also with the MDV pill. It's a pill, and lots of scans, lots of blood work. You're watched like a hawk. There's a 2/3 chance you'll get the drug, and a 1/3 chance you don't. In a month or so, we have 2 other trials likely to go on. One is you haven't had Taxotere, but you're going to start. You may want to consider this trial of Taxotere or Taxotere plus Revlimid. So you're bound to get something. The question is whether or not you get Revlimid as well. And the more exciting trial is this immune treatment called ipilimumab, and that's for hormone refractory guys. I haven't been told if it's Taxotere pre or after Taxotere, but that's using an immune-based treatment for hormone refractory guys. So there's 4. And thanks, Lou, for bringing that up. 2 of them are. Yeah, the first 2 that are active. ProstateOncology.com, www.
Dr. Lamb, if you're in an HMO like Kaiser or some other HMO, are you still eligible to come up and take your trials?
Yeah, but it's really expensive because of the visits and the blood draws, and the scans are done at designated places. Not so. If, for example, you're in Kaiser and you have to do bone scans and CAT scans, the trial can't take the Kaiser scans. So I think Kaiser has one or the other trial going on, so that would be an option.
The questions? Let me just ask one of my own then. I ask this of a lot of the experts. What do you see in the next 5 years?
So, just the last slide we went over, it's, there's a lot of new things with hormone refractory disease. With early, newly diagnosed patients, there is refinement of what's available. So, surgery is getting better, seeds are getting better, high dose rate seeds are getting more accepted. Focal freezing is gaining some momentum. There's going to be a lot more acceptance and data on the safety of active surveillance, meaning just watching it. You don't really have to treat all cancers. And those are the things.
Very good. Well, thank you so much for coming. We
Thank
do
you.
appreciate it.